Med Conversations.
Hi everybody, welcome to our first Med Conversations episode with visuals. We've decided to give YouTube a go. Coronavirus has pushed us into uncertain and sometimes exciting times. I'm Bec, this is Davor.
Hi everybody.
And you're listening to Med Conversations and you're watching Med Conversations.
Yeah. What are we talking about today, Bec?
Today we're going to be talking about my absolute bread and butter. It's insulin management in inpatients.
So Bec is a second-year endocrinology registrar, and I think making this episode has been a cathartic exercise of all the things she wishes other doctors knew.
I reckon we should just get straight into it.
Sounds good.
So I think one of the first things to talk about is the fact that I think that no one really knows a lot about insulin. And it's one of those things that you never really get taught much about in medical school. And then as soon as you start working, it's just assumed that you'll know. And I think it gets a bit of a bad rap. People seem to, it's a huge joke some of the time.
I 100% agree. No, I don't think it's a joke. I agree. I think everyone is faking it, and then no one knows that everyone's faking it until you get a few years in and they're like, what was that about?
Yeah.
No one was managing these sugars properly.
So I think it's one of those things where everyone's going to have a lot of questions that they think are stupid questions, but if everyone holds the same questions, then they're not stupid. So the good thing about engaging in something like this by video is no one will know the degree of your ignorance, and that's okay. So we'll talk about targets for blood glucose, different types of insulin, how you decide how to treat a patient who's come into hospital and you're admitting them and working out what to do right from the start, how to titrate those doses in hospital, how to get a patient ready for discharge, and also some useful resources that you can use.
So you're basically trying to put yourself out of a job covering all this?
Yes, that would be my intention.
All right.
Okay, well now over to you, Davor. Tell me, what are normal blood glucose levels?
So inpatient glycemic targets in non-pregnant adults. So I don't know the exact answers to this, I'm going to be 100% honest. So this is what I think. I think for a person with diabetes who's otherwise healthy, you'd want 7 to 10. Is that correct?
Okay.
Okay.
Not quite.
Okay, not correct.
But that would fit within the realms of correct. And I think that there isn't really a right answer. And if you're shooting for 7 to 10, that's probably okay, but it's too high for optimal glycemic management.
6 to 10?
So we're actually looking more for 5 to 10.
I should stop saying things to confuse people. All right, what she said.
Yeah, so 5 to 10, and it actually does depend on the person. So in general, in an inpatient, you're looking for blood glucose of 5 to 10, and that's partly to avoid hypoglycemia. 4 is actually normal, but if you're aiming for 4 and you hit 3.2, then that's bad news. So that's why our general target is 5 to 10 millimoles per litre. Patients in renal impairment are more likely to have hypoglycemia. So in those patients, 5 to 12 is the aim.
Why is that? Why are they more likely to hypo?
So patients with renal impairment who are on insulin tend to get stacking of their insulin doses, so they don't clear it as well. In frail, multimorbid patients, again, just trying to avoid the hypoglycemia, that glycemic target is 5 to 15. It doesn't really matter if it gets higher, but really what you're avoiding there is symptoms and sugars that are so high that they're going to significantly affect their healing. And then in end-of-life care, we don't really care what the numbers are. We care how the patient is going, and I think that applies to everything.
Yeah.
And here is, glycemia is just no different.
That's something I see a lot of, though, that people get really concerned when people are end of life or very frail, have sugars around 20 or so, and if they're not symptomatic, then it doesn't matter.
Yeah, as long as it doesn't look like it's going to get worse. You don't want to go into DKA.
Yeah.
All right. Oh, here's a bit of a cheat sheet, but I just wanted to briefly give a shout out to the HbA1c. I think something that a lot of
your bro.
I think this is an interesting thing that a lot of people don't realise, that the HbA1c is not the blood glucose. So the average blood glucose is actually a little bit higher than the HbA1c, but Basically, this is a measure of the glycemia over time, over a 3-month period. And I'm not going to go too into it, but I just wanted to show you this list of different glycemic targets looking at HbA1c, not glucose, in different groups. So these are patients with type 2 diabetes, and this is from the MJA, the Medical Journal of Australia. So patients who are only on lifestyle modification or metformin, the aim is 6%. So aiming for an HbA1c of less than 6%. And we'd really aim that for everyone, except for the risk of hypoglycemia. So patients who are on any other anti-diabetic agents other than metformin or insulin, we're aiming a little bit more generously, less than 6.5%. Those on insulin is less than 7%. And I think this is the number that I want you to be looking at. Your average doctor, 7% is going to be a good one to hold in your head.
Yeah, right. So really, only endocrinologists, the pros, will be going for less than 6. Is that right?
No, so patients who are not on insulin or just on metformin are aiming for less than 6. Absolutely.
But if you remember one number though, you're saying it's 7.
In the context of patients on insulin,
okay.
Yeah. Sure. So then patients who have had diabetes. And part of the reason that I'm saying 7 is diabetes of longer duration. So these are most of the patients you're seeing in hospital, or those who have clinical cardiovascular disease is also less than 7, regardless of what treatment they're on.
How long is longer duration?
So I don't think they've got a definition in here, but certainly 10 years would be my interpretation of that.
Fair enough.
Patients with high risk of hyperglycemia, we're looking at less than, I've circled the wrong thing, less than 8. And really, this is what we aim for in a lot of patients who have multiple comorbidities and who are older. So I think that in practice, if you just think of 7 and 8, so 7% is your average person with long-standing diabetes who's on insulin, you're aiming for their HbA1c to be less than 7. And for patients who are old and crumbly, lots of other things going on, or they have lots of hypos, or they're at risk of quite significant hypos, then you're aiming for less than 8.
Sounds good. All right. I think your bro HbA1c should be happy with that. So why does this all matter, Bec?
Yeah, so I think that glycemia is not just a number. We have to think about what the consequences are of high and low glucose. A third of patients who are inpatients in hospital at the moment have diabetes.
That's so many.
It's extremely common. A lot of these may be undiagnosed, and there's a study done at a hospital, or still in progress, at a hospital in Melbourne, the Austin where you used to work, where they did an HbA1c on everyone who came through the door who had a full blood examination. And they found quite high numbers of patients who weren't known to have diabetes but actually did. And the number evades me at the moment, but it's common.
Lots.
Hyperglycemia is bad. It can increase the risk of infections because of dysfunction of the white blood cells and macrophages. And patients can recover more slowly from illness and from surgeries. It can develop an acute kidney injury with very severe hyperglycemia due to an osmotic diuresis. Yeah. And hypoglycemia is bad news, and you probably know all about that from a neuro point of view.
Yeah, it's bad for the brain to not have enough sugar, is what neurology has taught me. I know we see, we actually have seen some really bad cases of severe hypoglycemia, which presents with like an MRI lesion that took us a while to figure out what on earth this thing was, and then we eventually figured out they just had really bad hypo. So it's bad news.
Ooh. All right. So I think that this looks a bit dry, but it's going to be helpful for the rest of getting through this episode. So I wanted to go through the different kinds of insulin. So the insulin can come in different preparations, mixed with different things, or prepared in different ways to allow it to last for longer. So we've got ultra long acting insulins that have a half-life more than 24 hours, all the way down to ultra rapid insulin that is onset within minutes and only lasts for 3 or 4 hours. So I think that insulin is one of the rare things where you're better off using brand names. So I can tell you all the generic names of these things, but it's not helpful because I think it increases the risk of drug errors.
Yeah.
What else increases the risk of drug errors is two things. One is that you can see here that
Lantus is one of my favorites. Yeah. Delicious. I'll correct it.
Yeah, thank you.
Lantus. Even I know that one.
So unfortunately, I don't know if you've come across this, Davor, but did you know that Lantus is no longer?
No.
Lantus
Don't do this to me.
So
now Lanuts. It's a rebranding. We're not patented. They call it Lanuts. Well, slightly different molecular structure that does the same thing.
Did you know that it's gone off patent?
No.
Okay,
we're not joking now.
Yeah, no, now we're not joking. No. So it's not Lanuts, but it's opticillin. So actually, during the process of me writing this podcast, I found out that Lantus has gone off patent. So
Lantus as well.
Yeah. So opticillin, probably most of you might not have ever heard of it. It's new. It's going to replace Lantus in late May, early June of 2020.
No way.
Yeah.
Oh my God.
So this is a long-acting insulin. It's the most common one that is used, at least in my practice, and it lasts for a full day, a full 24 hours, more or less. There are other long-acting insulins that also last more or less a full day: Semglee, Toujeo, and Levemir.
Levemir I've heard of, so I presume that's what we use in Australia.
Toujeo is also becoming one of the most commonly used insulins. I think we're going to see a lot more of it. Toujeo is very similar to opticillin or Lantus. It's insulin glargine, but it can come in a more concentrated preparation. So patients who are on really big doses don't need such a big volume. And it's thought to have a slightly more stable profile.
Okay. Can I cross off Semglee at least?
I think they're all. We're going to see a lot more new insulins, but yes, you can cross off Semglee, and then maybe if we're having this discussion again in a couple of years, everyone will be talking about Semglee.
Okay. Sorry, I don't want to get us off into the weeds. Here. I love this pen.
Is that a weed?
It's weed. Anyway, don't take my weed away from me.
I'm just making sure it's
green,
color appropriate.
What's the difference between ultra long and long? Why on earth would you want an insulin that lasts longer than my boy Lantus?
So insulin that lasts a really, really long time can develop, once it reaches steady state, can be very steady in the background as a background basal insulin. So it means that the timing of the dose doesn't matter as much. You can have it with breakfast on one day, lunch on another day.
And you can't do that with Lantus or opticillin.
No. So all those things in the long-acting category, they all need to be taken around the same time every day. And I'm about to show you a graph with all the different kinds of insulin. So maybe we'll just shoot through this a bit more quickly. So intermediate acting insulin, Protophane is really the only one that I see used down in Melbourne, but Humulin NPH is another intermediate acting insulin. Then there's short acting insulins. Act Rapid is again the one that I see most of. Humulin R I don't see very much of.
Act Rapid and Nova Rapid are not the same.
They're not the same. So this is a bit of a pet peeve of mine. I think that Act Rapid gets used a lot in emergency for some reason, but actually Nova Rapid would be.
Sounds like it acts rapidly. It's good branding.
It is good branding. Nova Rapid acts more rapidly than Act Rapid. Go figure.
That's very confusing.
So
this is the one you want. So really, there's not really much role for Act Rapid.
Well, there's lots of role for Act Rapid, but often in quite specific situations. So Act Rapid takes a bit longer to kick in. So patients with gastroparesis who are absorbing, easy for me to say, who are absorbing their carbohydrates a little bit more slowly would benefit from having a kind of insulin that's a bit slower in onset. So that's where Act Rapid really comes into its own.
Okay.
Ultra rapid insulin. So this is Fiasp. It's similar in makeup to Nova Rapid, but its onset is much quicker. And so what that means is that instead of taking the insulin 10 or 15 minutes before a meal, you can take it with the meal.
Mm-hmm.
So that's quite new, and I think that's coming in and something that we're going to see a bit more of in hospitals. Then we've got the pre-mixed insulins, Ryzodex 70/30. This has also just come out in the last couple of years. So with dinosaurs like Davor.
Terrible name, Bec. It doesn't even sound like an insulin.
And that's a big concern, I think.
Seriously? I don't have anything in the name that sounds like insulin.
Yeah.
Anyway.
Unlike Humalog, which is basically rhymes.
Yeah.
So Rhizodexulin is a kind of insulin. It's pre-mixed, as all of these are in this box down here. So it's 70% of this guy, Tresiba, insulin Deslodec, and 30% a rapid-acting insulin, essentially Novo Rapid. So I think of it as being an ultra long mixed with Novo Rapid. And anything that's got anything rapid in it needs to be taken with a meal. So you have to take Rhizodec with a meal. So
you have to take it 3 times a day?
No. So because it lasts for so long, the advertising for this insulin is that it would be once a day. But what we often do in practice is prescribe it BD. But it shouldn't be given any more than twice a day. Then we've got Novamix 30. Humalog mix 25, Humalog mix 50. These different numbers refer to the different proportions of the fast-acting and the intermediate-acting insulin, because all these things on the second dot point are a combination of an intermediate-acting insulin with a rapid-acting insulin. So Novamix 30. Yeah.
And always the larger number is usually the longer-acting one.
Yes, which makes sense, doesn't it? That you're
maybe 2.
Yeah. So it makes sense to me because I think that if you're going to have something a couple of times a day, I know that the overall amount of basal insulin that a patient should have should be around the same as the total amount of bolus insulin they have. So often Novamix 30 is given twice a day, but can even be given 3 times a day. And if that was a split 50-50, as Humalog mix is, that means that there's got to be a really big proportion that is bolus.
So I distracted you a lot on this slide. What are the key points you wanted to get out of this slide?
So the key points I wanted to get out on the slide are actually on the next slide. So just wrestling the pen out of your hand. Yeah. So what you can see here is these kind of insulins just charted on a graph. So if we start with the green line that you can see there, that's your Lantus or Opticillin or Levemir. So generally Lantus has or Opticillin actually has a slightly smoother profile than that, but it comes into effect a little bit faster and then does taper off a bit towards the end of the 24 hours. The red line...
Can I just make a point? I think this is important for noobs like me, because I always worry about giving Lantus at night, like giving them like 50 units of Lantus if their sugars aren't that high at night, and I'm worried that they're going to hypo overnight. But it sounds like actually they won't hypo until breakfast, and then they'll be able to get food.
I think that's a really good point. So it's really very important to understand the difference between a basal insulin like Opticillin or Lantus, which we actually recommend that they are given at night. And because there's not a sudden boost of insulin, it doesn't matter if you give it with food or not. And that's just something that goes on in the background.
So you know we were doctors because our handwriting is so bad.
It's just a real Pollock of it. I should also say I got this graph off the Royal Australian College of GPs website, and they had referenced it, and it's from some National Osteopathy Association.
Yeah, don't follow these.
Good enough for them.
Too far.
Good enough for me.
It's a good graph.
It's not actually entirely accurate, but it's good enough for these purposes. Okay, and so you can see the pre-mixed insulins, so the red line there. So that'd be something like Novamix. It's got its boost of rapid acting that gets you through a mealtime, and then it's got this this intermediate acting component that's lasting around another 12 or 14 hours.
Yeah, cool.
And the short acting insulins, that's your act rapid. It's not, no, so that's the yellow one.
Oh, yeah.
So short acting as opposed to rapid acting.
So there's a Nova Rapid with the black one.
Yes.
And let's see how that's spikier.
Yeah, it's spikier. So maybe if we use we use a pointer, it might be a bit easier to see.
Yeah.
There we go. Yeah.
So this red one, no, this black one,
which has now been coloured in red. Have we lost you?
is not rapid, and the yellow one is act rapid, which is not as fast as Nova rapid.
Correct.
And this is the ultra fast one. Look at that.
You're making that yourself. So that's endogenous insulin.
Well, do we have the ultra fast one on here? No, because the osteopathy association.
You probably didn't know about that. So the ultra fast one is FASP, and that's actually also
That's right.
Yeah, perfect. That will do. All right. I think we've laboured on this long enough. I'm going to tell you a story.
Okay.
Davor, if you could kindly draw Prakash as we go. So Prakash is a 62-year-old man with type 2 diabetes diagnosed 10 years ago. He's on metformin 2 grams once a day and has no complications, no other past medical history, and doesn't take any other medications. He, when you start taking his history, he sends you a link to his LinkedIn account, which describes him as an autodidact polymath from Home Alone. I don't know if the Home Alone bit is on his LinkedIn. He's a non-smoker, and he's come into hospital with 6 days of dyspnea, cough and fevers, and this is all we're trying to keep. Trying to keep it all very topical. So he's got COVID-19 pneumonia, and he's hypoxic, requiring 2 litres an hour via nasal prongs. So he's not well, but he's not extremely unwell. But he does have an acute kidney injury.
Okay. Can
you please draw the kidney injury? Thank you. Yeah, they look pretty injured.
Yeah.
And that is not suitable for children. All right. How are you going to manage his diabetes in hospital?
Wasn't paying attention to the case.
So metformin, AKI.
Okay, yeah. So that's bad news. So I would stop the metformin.
Okay, that sounds like a good idea. Why?
Because metformin, if they've got AKI, will give you acidosis.
There's a risk of lactic acidosis, yeah.
Yeah. So that's what I do.
Okay, and then do you think his sugars are going to... All right, well, let's see some answers. So we need to find out a little bit more. So you need to find out how good he was at home in terms of his control. So he usually checks his fasting glucose once a week, so we don't have a lot of data, and it's usually around 5. Is that in the normal range?
Yeah.
Yes.
That's great.
He doesn't know what his HbA1c is. He just never had a hypo. Would you expect him to have a hypo on metformin?
No, so only glycoside and a few of the others give you hypos, but not metformin.
Not metformin.
Metformin is an insulin sensitizer. So if they're on metformin and they're on the same dose of insulin, and then you put them on metformin, that might cause a hypo, but by itself it can't cause a hypo.
Yes, I think that's a really important thing to know, especially for medical students. Metformin doesn't cause a hypo, but it can increase the risk in conjunction with other medications like insulin. In terms of Prakash's adherence to his medications, he also shows you his phone, and he's got a daily habits matrix app, and so he's gamified his metformin taking.
Good job.
And as I said, his renal function is quite poor now, with a creatinine of 150 and a baseline creatinine of 70. In terms of his current blood glucose, and I think this is really important as well to find out before you make these plans, his glucose is 11 in the emergency department. So he's already slightly above the range we'd like him to be in, but not too bad. His diet is normal. Despite being really unwell, he hasn't lost his appetite. So now that we know this information, which is all key information to find out before you make a diabetes plan, we can make some decisions. So yes, we'll withhold the metformin. I would always start an over rapid sliding scale in a patient who has diabetes. It's there just in case. There are some exceptions, but I think as a general rule, it's pretty fail-safe.
That's interesting, because I was also previously taught that no one should be on a sliding scale if they're not on long-term insulin as well.
Yes, so that is a very good point, which I'm going to go a little bit more into. So we're charting it, but we're not wanting that to be their only insulin. We're charting that to find out if they need it.
And the HbA1c, why do we care about that? Because it's Kasha's a GP thing. Why are we worrying about that here?
Yeah, so we want to check the HbA1c because the control that he had at home is important to know, so we know whether we need to intensify his therapy.
Yeah, so we're thinking about his discharge, right? So Prakash will eventually leave hospital, and his insulin and his diabetes medications will probably change. And so if we don't know what his baseline control is, which is best measured with HbA1c, we're not going to know how to change things. But we'll come to that in more detail. But it seems like the main things that you want everyone to think about when they admit someone with diabetes, and this is great long case fodder as well. So if you're doing long cases, these are the questions you should be asking as well. So what's their control at home like? How adherent are they to the medications? And they're separate questions because they may be very adherent but have bad control. What their renal function is and what their current status in hospital is.
Good. Let's press on.
Okay.
All right. So we said we'd start a sliding scale.
Mm-hmm.
What is a sliding scale? This is tough.
So this is another one of those things we were talking about before where everyone isn't quite sure what a sliding scale is, but I think everyone else knows. So they kind of make up their own thing, and by the time they're HMO3, everyone has got their own slight different variation of what they think a sliding scale is. The one that I came up with was 12 to 14 was 2 units, 14 to 16 was 4 units, 16 to 18 was 6 units, greater than 18 was 6 units, and called HMO. That was my one, one size fits all.
Yep. And to be honest, that's not too bad. What I'm going to show you is the sliding scale that our hospital recommends. I say they recommend it, but to be honest, it's not very widely publicised. So we have a secret recommendation within the endocrinology unit that everyone else is expected to just somehow absorb through the waters. So it doesn't matter too much, and I think it's important that if you're watching this and you don't work at the Royal Melbourne Hospital, that you find out what your hospital's recommended standard sliding scale is. And it's also really important that you don't memorize this as the sliding scale that you use for everyone. So it should be somewhat individualized. As someone who's doing consults and seeing patients all the time, I'll individualize them quite a lot, but really it's not rocket science, and I think we need to keep things quite simple. So I use this, I would recommend this as the base, and then subtracting or adding 2 units either side of this depending on the patient's level of insulin resistance.
Okay.
So I think this is another really important concept to understand, the concept of insulin resistance. So patients who are very overweight with type 2 diabetes are going to be more resistant to the effects of insulin than someone who is slim with type 1 diabetes. Another way of telling how resistant they are to insulin is finding out if they're on insulin at home and how much they're requiring. So these are just general rules. So this is a blunt tool, but someone could be thought to be very insulin sensitive if they have type 1 diabetes. If they're already on insulin, but their total daily dose is less than 40 units. So that might be if they're on 20 units of Lantus and 6 units TDS of NovoRapid. Sorry, Lantus doesn't exist anymore. 20 units of Optisolin. Or if they're less than 60 kilos, that's quite small. So in those people, I would say that that 4 units would become a 2. And the 5 units would become 3, the 6 units would become 4, etc.
Basic addition and subtraction.
Yes. And so total daily dose of insulin more than 80 units, or body weight more than 100 kilos, you've been wanting to give them more.
Okay.
Good. And this is how I write it up on our drug chart.
Very impressive. This is important though. I often forget to write this.
So with EMR, I think this is all going to look pretty ridiculous to people who already have electronic medical records, but and it's probably going to be built in. But yeah, I think these are 2 important things to point out. Yeah,
I got a risk man once for not writing that down. That means I got in trouble.
So TDS with meals, what do you reckon about that? Why?
Because they might hypo otherwise, is the main reason.
Yeah, so the amount of insulin that a person can tolerate depends on how much is coming in at the same time. So how much carbohydrate they've got coming in. If you get paged to give a stat dose and it's 9 o'clock at night and their blood sugar is 16, can you just give what the sliding scale says?
No.
Yeah, so a good standard rule that someone told me the other day, I've never thought of having a specific rule for this, but I think a good thing to tell interns and everyone else is to look at the sliding scale and give half of that.
Okay. So this is for stat insulin, which is different.
Outside of meal times.
Yeah.
So if their blood sugar was 13, you might give 2 or 3 units rather than 5. But if they were having a sandwich at the same time, 5 would be okay.
Yeah.
Yeah, your writing's really beautiful. Calligraphy.
Yeah, that's it. What? Sliding scale. Sliding scale. All right.
Okay, I think we should push on.
Okay.
So we got Prakash, and we said that we started him on a sliding scale, partly to see how much he would need. He's currently on nothing else, just the sliding scale. And the next day you have a look at his chart, this is what you see.
Yeah, so he's still pretty high. He's high post-breakfast, he's high post-lunch, and he's high pre-breakfast. So he needs some basal insulin, I would say. Yeah,
and so you've also got the HbA1c that's come back, and so what would his aim be?
How long had he had diabetes for?
He's had diabetes for more than 10 years. But he's got no complications, and he's on the younger side.
And he's not on insulin. So I would say, is it less than 7 in him?
Yeah. So he's not great. We want to send him home on some intensified therapy. Yeah. We're already thinking about discharge. But let's talk about inpatient management first. I agree. We can't have someone just on a sliding scale. It's not going to achieve as tighter glycemic outcomes as we need for him to get better from his COVID. So let's think about how we're going to start him on insulin. So the reason I say insulin is because in inpatients, we need to shift towards thinking about mostly insulin. It's not a good time to start an oral hypoglycemic agent.
That's interesting.
In a sick patient.
Yeah, okay.
This is also a bit controversial and things are changing a bit. But the general conversation has been about, particularly in the US, they generally don't give oral hypoglycemics to inpatients at all.
Wow. I didn't realize that.
But that's actually just been changing a lot in the last couple of years. And I think that the US are actually moving a little bit more towards what we see a little bit more in Australia, which is giving oral hypoglycemic agents a little bit more.
I give glucoside all the time. Is that naughty?
Yeah, so I wouldn't be giving glucoside in a patient who has an infection. Glucoside's a really powerful anti-hypoglycemic medication, so you certainly could start it in hospital. But in a patient who's had a stroke, which is probably the kind of setting that you're seeing them in.
Yeah. But the important thing you always have to check is renal dysfunction.
That's right, and I think we're getting a little bit off topic here. So what's really important, the point that I wanted to get across is that in a sick patient, you're managing them this is the hospital phase. We're not yet talking about what's going to happen when they're at home. This is the hospital phase, and that's going to be different. The management is going to be different to what they're on when they go home again. So if you, that was very neat, good handwriting. But if you just erase that, I'm going to show you how to start insulin in this patient.
Okay.
So it's important to get the patient's weight, because there are some simple weight-based rules that you can use. So the options are that you can start him on basal bolus insulin or basal plus. So basal bolus insulin means a long-acting insulin like Lantus or Opticillin, as it's now known, and a regular dose of short or rapid-acting insulin with every meal. That would be basal bolus, like Lantus and Nova Rapid, classic basal bolus. Basal plus would be just the Lantus or just the Opticillin, and then a supplemental sliding scale.
Okay.
And that's a bit more conservative.
That's what I usually do.
And I think that's more reasonable for you to be doing without the oversight of the endocrinology team.
Yeah. That's right. That's my wheelhouse. That's where I feel comfortable.
Yeah. And so what kind of dose are you looking at for this guy?
So we can't do what we usually do on the podcast where I look smart because it's written on the podcast. It's 0.4 units per kilogram, Bec, split 50-50. Did you know it should be 0.3 units per kilogram in the elderly?
I've also, yes, well done. So I've also written something on this that's actually not entirely correct. In renal failure, you should actually be even more conservative and go to 0.2 units per kilo.
Wow.
But going back again, so the total daily dose is going to be around 0.4 units per kilo. So let's look at Prakash. He's an 80 kilogram man. So the total daily dose will be 0.4 times 80, which is 32 units.
Mm-hmm.
I'm worried that by broadcasting this to everyone that you might internalize 0.4 units per kilogram is the Lantus dose. It's not correct. That's the total daily dose in a patient who's going to get basal and bolus. So you want to halve that. So really, if you are going to memorize something and make mistakes and not look things up, really, I suppose the number you should be memorizing is 0.2 units per kilo is the Lantus dose.
Just look it up.
Look it up.
We have computers these days. We don't need to memorize everything. I certainly will be. So yeah, 0.4. But yeah, this is a fair whack of insulin to start someone on, and hopefully you would start to feel nervous when you write down 32 units of Lantus for someone who's never been on Lantus before.
But if you're an intern, you won't yet have a sense of what's a big dose and what's a small dose. So I think here's a good point for me to emphasize. Insulin is a dangerous drug. Don't stuff around with it. If you're not 100% sure, this is something to discuss with other people. Often when you're an intern, you might be on a surgical unit and your registrar might not know either, and they might give you a vague directive to fix someone's blood sugars. If you're not sure what you're doing, do not guess. Call me. I'll help.
That's why they make endo registrars so nice.
Guess with 2 S's.
Well, I wrote it. I know how to spell guess with a pen.
All right, so Prakash, 80 kilos, 32 units total daily dose, half Lantus and Nova Rapid or Opticillin. So half of that is 16 units. So you're going to chart 16 units of Opticillin. Now this is a lot higher than a lot of people tend to do, but this calculation is actually an underestimate. It's a conservative measure, so it's quite safe to use this equation again with some supervision.
Yeah.
So then the Nova Rapid dose will also be around 16 for the total day's dose. So 16 divided by 3, round it down. I always round down with insulin, so that'll be about 5 units TDS with meals.
Yeah. This
is if you're charting it regularly. You should also write on the order that it should not be given if the patient is not eating. So Nova Rapid, I want you to remember it as a kind of paired thing with meal. So Nova Rapid is only paired with meal, except in other certain situations.
Yeah.
If you decide to do a basal plus regimen, that would involve you charting just the 16 units of the Opticillin and the sliding scale as we discussed earlier.
Yeah, so it would not be the 32 units plus sliding scale.
No.
So don't make that mistake. That's something I could see myself doing as an intern.
So if you decide not to chart the regular Nova Rapid, then you'll just use a sliding scale. But what if you do chart the regular Nova Rapid? Would you still have a sliding scale?
Yeah.
Yeah. The sliding scale only gets activated if the patient's hyperglycemic. So it's quite safe. All right. So how did we go? We've still withheld the metformin. We decided to go with a basal bolus, and nothing is highlighted because his blood sugars have actually all been normal since starting. That was before the Lantus was started. Yeah. And then since starting the Lantus and the regular Nova Rapid, he's done beautifully. So everything's in range. The sliding scale wasn't used for a full 24 hours. He's starting to feel better. We're looking towards getting to discharge. His renal function's picked up. What do you do?
Yeah, so we're now going to start thinking about what we're going to discharge this guy on. And this is why we sent the HbA1c, right? So we know that metformin, and he's on the max dose of metformin, is that right? 2 grams?
Yep.
He's on the max dose already, so we need something else for this guy. So here, I don't know if this is right, I would think about starting some glucoside in this guy.
Yeah, that's really reasonable. I just want to talk about this concept that we've already alluded to a couple of times, just to really emphasize this. Actually, Davor, can I have a pen?
Okay.
So if the person at home is very well controlled, and then in hospital everything's a bit up and down, you might increase or escalate their therapy or change them to insulin off their orals. But then if they were fine before, once they go home, you just put them on the same thing again. If they had terrible control at home, then you do your thing in hospital, which will again be totally different. Then you can't just go back to the same thing as before. That's a bad idea.
I'm glad we've got a diagram for this. How could you ever understand this concept without...
Well, and see how this house is sparkling? It's because it's better.
All right.
All right, good.
I'm taking the pen back.
Okay. So do you want to send him home on insulin? He's got 4 injections a day. He's still on a sliding scale.
I want to put him on glucose.
Yeah. So you've already said that, and I think that is very reasonable. So he, just to quickly think about some of the things that are impacting on his glycemia at the moment. He's eating a little bit less than usual, perhaps. He's also sick with activation of his HPA axis. So there's so what's the HPA axis?
Hypothalamic, pituitary, and adrenal axis.
Yeah, so he's in sort of flight or fright. Flight or fight.
Fright also works.
And so extra cortisol, adrenaline, and things like that are going to be driving sugars up, but eating less will drive it down. Maybe it's going to come out somewhere around in the middle. But as we said, he needs intensification of therapy, so that's what we do.
So yeah, that's why the HbA1c is like a really good thing to add on. It seems to me it's hard to order too many HbA1cs.
Yeah, just do it. I think every patient with diabetes should have an HbA1c. I definitely would recommend, before you call endocrinology, to have an HbA1c ready to tell us, or tell us that it's cooking.
Yeah.
Okay, so what we do for Prakash is we stop his insulin. We restart his oral therapies that he was on before. 2 grams XR metformin is the maximum dose, so we stop that.
Maximum.
And the renal function, as I said, is normal. Glycoside, I agree, is a good idea. So as you mentioned before, it's an insulin secretagogue. It makes your body secrete more insulin, and it's a sulfonylurea. It's quite a powerful anti-hyperglycemic medication. So it would be a good one to start here, and it's second line in Australia, alongside SGLT2 inhibitors and DPP4 inhibitors. But we're not going to talk too much about, So the important thing here is just the concept that we intensify. Then you monitor him on these new medications to make sure that he's not still relying on a sliding scale for top-up insulin, and make sure he's not having hypos with the glucoside. You motivate him to improve his lifestyle. Consider getting a dietitian review if he's sitting around in hospital not doing much else. And then you hand over. So this patient doesn't need an endocrinologist, but his GP is going to be really, really useful here. So to encourage those lifestyle changes, and also to continue to intensify therapy until he meets his glycemic target. So it's useful to tell the GP what kind of target you're aiming for.
Yeah.
And if you are a GP, you probably know that you will often have a better idea of HbA1c targets than most hospital doctors. But I think it's just important to work together here, because this patient's diabetes is now going to be managed by someone in the community.
This handover business is really good if you can do it. Because in this like terrible system of faxes being sent into the netherworld and then occasionally making it through a complicated system of tubes to the GP, if you have the time to pick up and briefly call them, that's amazing. But usually you won't have the time. All
right. Let's say that didn't happen. Prakash didn't get better.
Should we say some take-home points from Prakash's case? I'll tell you what I learned.
Okay.
HbA1c is very important. No, depends on.
You're just too high up on the screen.
It's very important. Remember Bec's diagram about the houses, which will help you remember the idea that you should take into account how people were before they went to hospital and use that to guide your discharge medications. And withhold metformin in someone who is in renal failure.
Good. Those sound like good take-home points.
Okay.
I've got some more for you coming up too.
Cool.
So let's just say that the same patient, he was going to go home, but someone put in a dodgy cannula, forgot to take it out, it got infected. He developed a Staph aureus bacteremia. Please see our other podcast. He had a met cool, fever, tachycardia, hypotension. He's sick. And in the setting of him being sick, his blood glucose goes up, as you can see by this skyrocket diagram to indicate
Very
the
helpful,
BGL's
because
skyrocketing.
these go up in the sky, much like the BGLs.
All right, next slide. Okay, so this is Prakash's glucose chart. So red is anything out of that target range. Remember, we said the target for this man is going to be 5 to 10.
Mm-hmm.
So he had an elevated blood glucose pre-dinner on Monday and required 4 units of sliding scale, and then went to bed in a normal range, and overnight, in the middle of the night, 2 a.m. was 10, and then before breakfast his fasting blood glucose was 12, again out of range and again warranting 4 units of sliding scale.
Yep.
It was controlled through the day without any more sliding scale, and then the following morning at 2 a.m. 10.2 again, and then before breakfast was 12.5, again out of range, and this time needing 5 units of sliding scale.
Yeah.
So what's the pattern?
So the pre-breakfast is the main problem, I would say. And then this is a little bit problematic as well. I would think as a first port of call, I like changing one thing at a time because I'm a noob when it comes to insulin. I would change the Lantus.
Okay. So the 2 questions I want you to ask yourself is, what's the pattern? Which insulin needs to change? And you've identified the Lantus or the Optisulin.
Mm-hmm.
And how bad is it? How bad is the problem? And therefore, how much should you change it by? So I think it's important to think about which insulin is active at the time of the glucose is out of range. And I think people who've been working for a while, this will be fairly intuitive, but perhaps not. And so it's important to think about it. Is the high glucose postprandial, is it within about 4 hours of a meal, or is it first thing in the morning, a fasting glucose, or in the middle of the night? And then think about the patient at 2 p.m. what's active in that patient's body. The lunchtime Nova Rapid will still be active, and so will the Lantus that they had last night, or so will the Protophane that they had this morning. Think about what's active at the moment and which component of that needs to go up.
Right. But when we pretty much always check just postprandial, right? No, we never check postprandial.
We tend to only check postprandial after dinner in hospital.
Yeah.
But if you're checking in a hospital patient, often the pre-lunch reading is actually a post-breakfast reading as well. So the best measure of an adequate bolus dose at a time of a meal is a 2 hours post-meal blood glucose check.
And that's something you should ask for.
Sometimes you should ask for it if you're concerned that somebody has very unstable glycemia.
Yeah.
And I think that the other thing is that a lot of the time the patient who has a hypo randomly won't be obeying the testing rules. The nurse will walk in, they'll be a little sweaty and shaky, and they'll find out that they've had a hypo at that point. And then you say, okay, well, that will be because of the Nova Rapid dose that they had.
Mm-hmm. Okay.
All right. So as I said, change the right dose, figure out which insulin is the problem, and then what's a safe dose titration? Again,
for me, 10%. Like my big fear, and it should be your big fear as well, is causing a hypo.
Yeah.
So I'm always erring on the conservative side. So 10%, I feel, unless it's like a tiny dose of insulin, like 8 units or something, I would usually aim more for 10%.
I think that's very reasonable. So I will usually feel quite comfortable titrating up by 20%, but I think that there is always a risk of a hypo, and certainly if you're not sure, then 10% is better, particularly in a patient who's not particularly hyperglycemic. And in terms of when to be more conservative, I would be increasing insulin by a smaller amount, and if you're decreasing insulin, I'd decrease it by a bigger amount. That would be a more conservative thing. It's riskier for you to give a patient an episode of hypoglycemia that's worse than a single episode of hyperglycemia.
Mm-hmm.
All right.
All right.
Can we
go to the wrong slide?
I think you went back.
Yeah.
Oh no, sorry. Okay, yes. So is it the same slide again? Sorry. Yes, here we go. So we increased the Lantus from 16 to 18.
Yep, that's exactly what I would have done.
And look at us now. So what you can see here is that the Lantus dose from that first dose increase, the 2 a.m. blood glucose is 8.2, down from 10.2 the previous 2 a.m. And then all the other glucoses are within the desired range. So that's great.
Can I say this is a good one to ask for? I'm always worried that people are hypoing in the middle of the night and that they've got rebound hyperglycemia. So sometimes you might see high blood sugars first thing in the morning, and if they're on a fair bit of insulin and I keep racking it up, I start to get suspicious. Maybe they're hypering in the middle of the night and then rebounding. And so this isn't routine. This is something you've got to usually specifically ask for on most wards. I don't know about the endo ward, but on most wards you need to ask for it. And I find it very reassuring because I say my greatest fear is causing hypoglycemia.
So a good thing to write when you admit a patient who's got diabetes, if you're concerned about hypoglycemia, is in terms of the frequency of blood glucose monitoring, I tend to write QID plus 2 a.m. So QID means before breakfast, lunch and dinner, before bed and 2 a.m.
Mm-hmm.
Okay, what if things were a little bit different? What if this was the pattern of blood glucose?
Even after I've upped?
No, this is
pre-upping.
This is an alternative reality.
Gotcha. So the Atlantis is still 16. So it's still pretty high.
So for anyone who's not looking at the video, what we're seeing now is the pre-bed glucose is elevated, and so is the 2 a.m. glucose, but everything else is within the normal range.
Yep. So remember when we looked at the Lantus graph, it was like pretty slow to get up there.
But also remembering that graph was from the Osteopathy Association, and the real profile of Lantus is more like that.
Yeah. What I was trying to say is that giving Lantus at night is not going to be that effective for this O200. Is that right?
No, sorry. So the O200.
Bec and Davor.
Yeah. So O2 the 2 a.m. At 2 a.m. Well, how long does Nova Rapid last for? 4
hours.
So you're giving Nova Rapid at around 6 o'clock. At 2 a.m., that Nova Rapid is no longer active, or no longer particular. It's neither here nor there.
Yeah.
So if you're looking at what insulin is active at that time, it's just Lantus at 2 a.m. But this is a bit more of a complicated case. So this is partly just illustrating that you can't just look at any number in isolation. So what we can see is that the eventual fasting glucose, the pre-breakfast glucose, is okay. It's within the normal range. It's not as tight as I would like for a 62-year-old man, but it's fine. But we're really seeing this spike after dinner. So going up to almost 14 after dinner.
What time is pre-bed 10?
9 o'clock usually.
So Nova Rapid would still help here.
Nova Rapid is still active in this patient's body there. Yeah.
So yeah, you might concentrate more on the Nova Rapids as the first move here. So you might increase that by 10%. I would, so maybe 1 to 2 units, which is not 10%, but we're dealing with such low units of insulin. I'd probably increase the pre-dinner insulin to 7, I think, and then that would hopefully deal with this. And then because the Lantus has less work to do, this one would go down as well. Exactly.
So I think that I probably would also increase to 7, but following the rules that I've told you about, we should only be increasing it by 10 to 20%. So a 20% increase would be going to 6.
Mm-hmm.
You wouldn't there are times where you might give 0.5 of insulin, but in general you wouldn't do that. So let's say we go to 6.
Good.
Fixed.
Perfect. Okay, time for a recap.
Okay, so this is the bit where I quiz you, and no one knows that you've got the answers in front of you. So what's your target BGL?
So generally 5 to 10, if you're going to remember two numbers, 5 to 10. If they've got renal failure, a little bit higher. If they're elderly or frail, a little bit higher. And if they're palliative, then we just worry about symptomatic hyperglycemia, really.
That's right. And this is inpatient targets, different in the outpatient world. Okay, key determinants of the way you're going to manage a patient in their diabetes. What do you need to know about?
So these are the things you need to check on admission. So their oral intake, the degree of illness, the pre-admission control, which is the HbA1c, and the renal function.
Great. Most inpatients should probably have their oral hypoglycemic agents withheld, particularly if they have an acute kidney injury. This is a little bit up for debate, so I'm not going to go too into it, but so glycoside, sulfonylurea, is more likely to cause patients hypoglycemia if you give it to them when they're not eating. But actually studies have shown that withholding glycoside can patients who are usually on glycoside who have it withheld are more likely to have hyperglycemia in hospital than the next guy in the next bed.
So without going into the rabbit hole of endocrinology literature, just stop the metformin?
I would withhold the metformin in a patient with an acute kidney injury or at risk of an acute kidney injury.
Anyone who's sick, really.
Anyone who's sick is at risk of an acute injury. Anyone who's sick or likely to get a scan. So in reality, it's more or less every inpatient.
Someone who has diabetes and is in hospital is probably going to get an acute kidney injury.
A lot of them. All right, but I'm keen to keep this as a summary, so we'll try and pull each other out of the rabbit holes here. Now, regular insulin, we started that on Prakash because he had more than 2 readings out of range. He needed the sliding scale more than twice.
That's really key.
This is important. If you do not feel comfortable starting a patient on insulin, and most of you will not, it's important that you get support with this. But commencing a patient on insulin should be done quicker than we usually do. And the way you start insulin is to weigh the patient and calculate a total daily dose of insulin. 0.4 units per kilogram would be the total daily dose encompassing the Lantus and the NovoRapid, or the Opticillin and the NovoRapid. You may choose not to chart the NovoRapid and just the Opticillin. And in either case, you want to have a supplemental sliding scale. The total daily dose in a patient with type 1 diabetes, an old patient or a very skinny patient, would be more like 0.3 units per kilos. And in renal impairment, 0.2 units per kilo.
This is done really poorly. I think in hospitals.
Very poorly.
I do it really poorly. Like I forget to check the channel. Like, whoa, this person's had like 5 sliding scales in the last 3 days, which is bad. We should be thinking about it with greater than 2 readings, because insulin is not a joke. Thank
you. That really means a lot. All right. When you're titrating insulin, make sure you're titrating the right thing at the right time. 10 to 20% is usually a safe increment.
I like 10.
10 to 20% is usually safe. If you're not sure, stick to 10, check it again the next day, and then you can go a further 10% the next day. At discharge, change the patient back to their pre-admission medications if their HbA1c was in target. There's no reason to send them home on what they required in hospital. Intensify their therapy if the first house was across. Take it to the second house. Intensify their therapy. If their diabetes wasn't well controlled before, this is a good opportunity to get it better controlled when they go out of hospital. If you do that, you need to institute follow-up. You should never discharge new insulin without a diabetes nurse educator review in hospital, or to see the patient once they're at home and call them up and make sure that they're going okay at home. We haven't really talked about this, so this is less of a recap, more of new information. But along those same lines, you should never discharge a patient on a supplemental sliding scale because it's very complicated for the average patient and usually not necessary. We sometimes do that in particular situations with specialist input, and that would be the only time. Whew,
it's helpful
okay.
for me to just rewrite the same thing.
Yeah, I mean, I think it's helping you solidify these things.
Yeah.
All right, so that's a recap of patient 1. We've got a few more patients to go.
How many more have we got?
We have a lot. I think we may need to do this in some episodes.
Should we go to episode 2 now?
We're right at the start.
Wait, it's like.
Yeah. So I think enough of us rambling for one day. We're going to split this into a few different episodes, but I just want to leave you with this. Download the Insulin app. Davor, do you have it?
No.
I don't know why I asked. Don't be like Davor and download the Insulin app. It is excellent.
Cool.
It's actually based on the New South Wales diabetes guidelines. And it's a point of care resource, so you can just plug in, my patient has high blood sugar, it's at this time, and then it tells you what to do. I think it's excellent. It's very user friendly, and it can also guide you through the things we've talked about tonight. So starting your insulin and things like that. So download Insulin. It's free.
Don't go off a half-remembered thing from one of my silly drawings and then put someone on the wrong dose of insulin. Download an app or just look it up on today.
Or call the endocrinology registrar.
They're so overworked. Don't call them. Don't call them.
All right. We will probably see. Yes. Sorry. Diabetes care in hospital. This is an ADA, American Diabetes Association, fact sheet that's really, really useful. It's not really a fact sheet as much as a set of guidelines. There's the Australian Type 2 Diabetes Treatment Algorithm, which is especially useful if you're a medical student or a GP, and it's beautifully set out. I wonder if we can.
So this is
more
chronic treatment. No, we can't show you.
We can't show you. And a list of the HbA1c targets that I showed you on that earlier slide. Then I've just got a link here to a really great summary of what to have ready before you call the endocrinology registrar from On the Wards, which one of our competitor podcasts don't listen to them. They're no good. No, they're
much better than
they're really great. Would recommend.
Professional. Yeah, as I said, Bec just is lazy and thinks if she can make a great podcast with great resources, then she just doesn't have to do any more work. So help her out. Thank her for making the podcast and check this list of things that you should know. I remember the first time I called an endo-reg as an intern, I just had absolutely nothing. I didn't know a single sugar.
It's not that uncommon.
Not a single sugar, not a single number. I knew they'd come in with a stroke, and that's it. She was really lovely. She was like, all right, so I want you to go grab the sugar chart. Let's go through some of the numbers together. So yeah, they're very nice, but don't exploit that. And look at these things that you should know. All
right, great. Thanks, everyone. We'll see you again soon with part 2 and maybe 3 and 4.
Yeah, we're now the Diabetes Podcast. Vidcast. Bye.
Bye.